for the next presentation. Filters in sepsis. Is there a rationale by Dr. Rajesh Pande? I request Dr. Rajesh Pande to present.
Good morning, ladies and gentlemen. At the outset, I would like to express my sincere thanks to the organizers, office bearers of Hyderabad branch and my friend Srinivas. We've been using filters for almost 2 decades now. So the question, if it is popping up, is there a rationale? That means possibly there is a problem. So we know sepsis still remains a major issue, a major killer in the ICU, and the mortality will approach 60% when we encounter septic shock patients. And the current definitions are that it is life-threatening organ dysfunction due to dysregulated host response. So they're talking about the immunology, dysregulated host response. And then, of course, you have the sicker patients who will be septic shock subgroup, who will be refractory to the fluid resuscitation, and they will have a high lactate, require vasopressor therapy. So here the cellular and circulatory metabolic abnormalities will be fully manifested, leading to organ dysfunction. So why are we thinking of immunomodulation in sepsis? Well, if you see, effective host response to an invading pathogen is very essential so that the infection is resolved. That's how normally we recover from milder infections. However, when there is an overzealous response to this initial insult, what we call as dysregulated host response to infection, we see this in sepsis as well as in ARDS. So literature sort of this filter literature sort of looks at both the things similarly. So this conceptual model that includes, the cascade, cytokine storm, and the release of all these, which may cause excessive immune response in some, but may cause immune exhaustion in some patients. So you have a spectrum from one end to the other, and as a result, we are confused as to what therapeutic approaches should be taken, whether we should take immunosuppressive approach or immunostimulatory approach. And our clinical practice is completely different because it is uh, based on clinical signs which are non-specific, and we look at the symptoms which do not tell us about the whether it is immunosuppressed state or immunostimulated state. And we do not know why the immune response is variable. Why somebody will be in excessive immune response, somebody will be in immunoparalysis, we don't know. And possibly the time from initial insult to clinical presentation would be the key, but then studies show that even with similar timelines from onset to the fulminant sepsis, a patient will have different immune profiles. They will behave differently. So some will have suppressed immune response, others will have overactive immune response. So we still have different phenotypes, whereas the therapy would be one given to all. And possibly the kind of pathogen involved, the virulence of the pathogen, the severity of the insult, and the genetic disposition of the patient, comorbidities, these possibly play a significant role as to what kind of response will the patient elicit. Now here you can see the immune response, as we know in sepsis ARDS, is very complex and differs from patient to patient. We know that initially the innate immunity will come into play, and we have this toll-like receptors that will identify the pathogens, the PAMs and the DAMs, and that will lead to a flurry of cascade and ultimately leading to cytokines. And they will manifest as damage. And these toll-like receptors are present in cells like dendritic cells, monocytes, macrophages, etc. And then they will play havoc and cause end organ damage. That's how it looks like. So if you see, you can have initially when you have the PAMs being identified by the toll-like receptors on the dendritic cells, macrophages, etc. You may have an early response where there is surge of cytokine mediators, and simultaneously later the adaptive immune system also comes into play, and you have the cellular immune response through the B cell activation, etc., and the humoral immune response through the immunoglobulin. And so you can see it here. And in some, you will have a suppression where there is exhaustion of these things, and there may be complete immunoparalysis. So some will recover, some will completely deteriorate and may not recover. So in a particular patient where we are, that is the dilemma. So what treatment to give, that is the big dilemma. And for sepsis, we have no magic bullet. Uh, the conventional therapies would include initial resuscitation, identifying controlling source of infection, broad spectrum antibiotics, and then we only talk about supportive organ dysfunction therapies. You give RRT, you do other things, you give protective lung ventilation, etc. So in a nutshell, when we have the pathogen invading in sepsis, it leads to an immune response, which could be pro-inflammatory or anti-inflammatory, and then there is sepsis-induced organ failure. So this brings into consideration that immunomodulating therapies could be an attractive option. So you could either suppress the immune system by using corticosteroids or TNF alpha inhibitors or recombinant IL-1 receptor antagonist, or you could stimulate the immune system by recombinant cytokines with proliferative effect, CSF, GM-CSF, interferon, IL-7, or you could modulate the immune response. Either you extract the immune mediators or you neutralize the immune mediators. So extraction of PAMPs, DAMPs, host inflammatory cytokines, neutrophil extracellular taps. This is what is the focus of this type. This is what the filters will do. So extracorporeal blood purification is the broad term given, simple term given. And you can see that the targets here would be that you remove the pathogen, remove the endotoxins or the other components of PAMPs, and remove the activated leukocytes, reprogram the leukocytes, and also remove the circulating cytokines, hoping that this will change and arrest the cytokine, the dysregulated cytokine response. Now, why this extracorporeal therapy? Because there are many theories that have been proposed how it is helpful. So they say that when we are removing these from the blood, it creates a gradient, and the inflammatory cytokines from tissues will flow into the blood from where you are sucking them out. So eventually the immune function will be restored. And a threshold comes where the this inflammatory cascade will come to a halt. So that is the philosophy behind using this. The first therapy that was used was polymyxin B, hemoperfusion. So you can see various therapy being listed here, and this is the molecular weight of the substances. You can see lipids, you can see the interleukins, and then you have the lipopolysaccharide. So some therapies will only handle this endotoxin, and some will only handle the cytokine but not the endotoxin, and some like Oxaris will handle both. So these are the extracorporeal blood purification techniques. Mostly we are using the adsorption therapies like endotoxin absorbent polymyxin B impregnated absorber, or there is unspecified adsorption, which is cytosorb, and then you have combined, which will remove both endotoxin as well as cytokines, that is Oxaris. So the philosophy behind endotoxin absorption therapy, this was licensed in Japan for 1 or 2 decades before it hit the international market and India market. So they said the gram-negative sepsis will sort of throw out a lot of endotoxins, lipopolysaccharides and its fragments. They will activate the inflammatory cascade and the cytokine storm. And studies identify that the endotoxin assay level was more than 0.6, then this was associated with higher severity of illness in the septic patients. So this absorber, which was by Toremixin, it comes by the commercial name of Toremixin, this could absorb this. There's another one, Eltico. So they will absorb and remove the endotoxin removal. The idea was that the further cytokine, downstream cytokine stream cascade will be completely stopped. So the first study, which was presented in our ISCCM before it got published, Agra conference, was by Dina Cruz from Italy, where it was a small prospective randomized control trial. Number was small, 64 patients, and they used the hemoperfusion with polymyxin B, 2 therapies in 24 hours, versus the standard treatment in patients of septic shock or severe sepsis who underwent emergency surgery for intra-abdominal infection. And they showed that there was a remarkable survival benefit, and the vasopressor indices and other things were all better. So they concluded that when you add this to conventional medical therapy, this is effective. But they said at the same time, because our numbers are small, we need to go for a larger study. At the same time, people tried to start it early. This was a Japanese group, so they gave within 6 hours versus when they gave beyond 6 hours. And they showed that when they gave within 6 hours of initiation of this sepsis, then they could wean the catecholamines early, and they could also wean from ventilator early. So this difference they showed. So the people started believing that we should start it early. There was a large trial that got published in JAMA. It was done in the US, and it was a good study, the Euphrates study. So what they did was they selected the septic shock patients of any origin. Then they did their endotoxin activity assay levels. If they were more than 0.6, they were chosen because the endotoxin activity was high. That is where the filter works. And then they divided into two groups, one where the two hemoperfusion filters were used in 24 hours in addition to conventional therapy. In the other group, a sham catheter was put, so that that was the blinding kind of a thing. And they unfortunately could not demonstrate even 5% mortality benefit. So it came out as a negative study, large randomized control study, nicely done. So it was negative. Then they pondered over the study, but again, this is like data doctoring or data torturing, as Atul calls it. So they did a post hoc analysis, and they found that if they take the subset of patients where endotoxin activity level was between 0.6 and 0.9, then there was remarkable mortality difference. And they questioned the validity of this test beyond 0.9, but then you can interpret it any way you like. Second therapy is the cytokine removal. It came with cytosop. Then many other filters came. So this will have a large surface area, and it can remove anything up to a cutoff size of 60 kilodalton. So it can remove both pro as well as anti-inflammatory mediators. And they again suggested that 12 to 24 hour session for 2 to 7 days, etc. And it will absorb the inflammatory mediators plus substances like free hemoglobin, myoglobin, bilirubin, bile acids, PAMs, then so many other things, and DAMs. So that was the idea. But is it good? Cytokine removal, all of us have used in our clinical practice. Uh, there are registries, there are very small observational studies. There is no randomized controlled trial on the use of cytosol or cytokine removing filters. There was a study from Gurgaon by Dr. Yatin Mehta et al., where they reported favorable, this was an observational study, favorable outcome in sepsis and septic shock. They also proposed a cytosorb scoring system where they said that it can help you in identifying patients. And non-survivors had a high mean score, so don't use it in those patients. So this was the score. These were the parameters that they included. Now, it included serum lactate, in terms of the biomarkers as well as the procalcitonin CRP. Then they had SOFA Apache 2 scores incorporated here. And ideal time to initiate, they said, is when the total cytosop score is less than 8, and beyond 30, possibly it should not be used. The third one is Oxaris, which removes both endotoxin as well as the cytokines. Now, this is a triple three-layer structure and is highly electrically charged. The first layer, as you can see here, this is the triple layer structure. And the first layer here will absorb the cytokines and will remove any solutes less than 40 kilodaltons by convection. Then there is a middle layer here, which will remove the endotoxin. And the outer layer, which is in direct contact with the blood, is coated with heparin. So it minimizes local thrombogenicity. So my closing remarks are, again, Oxaris has not made any difference. There is no large randomized controlled trial that we need to understand. So in the last 3 decades, many RCTs have evaluated therapeutic modulation of immune response in sepsis and ARDS with no consistent benefit, most likely because of the heterogeneity in clinical and biological characteristics. So, however, the evolving understanding of molecular mechanism of sepsis and ARDS suggests that filters but that field may need to move beyond syndromes to treatable traits, and then maybe we select out and then use there. So filters so far has not shown any evidence of great benefit. Science is also moving a little away, like Pradeep highlighted. So we are looking at the biological mechanisms here and then identifying the treatable traits and then looking for certain biomarkers, and then maybe we will be able to handle epithelial injury, endothelial injury like that, or where immune system is exhausted. So I think we are going to very focused thing. The problem is we don't have the biomarkers as yet, which are commercially available, where you can identify what is the problem with your patient. Thank you for your attention. Thank you very much.
Thank you, sir, for your excellent talk. I think there's still a lot of debate about use of filters as per your talk. I would like to now